Hello and welcome. I'm Catherine Banwell, your host for today's program. Today's webinar is a continuation of our Thrive series, and we're going to discuss how to manage life with an MPN. Before we get into the discussion, please remember that this program is not a substitute for seeking medical advice. Please refer to your healthcare team about what might be best for you. Well, let's meet our guest today. Joining me is Dr. Raajit Rampal. Dr. Rampal, welcome. Would you please introduce yourself?
Hi, thank you so much for having me. I'm Raajit Rampal from Memorial Sloan Kettering Cancer Center, where I focus on myeloproliferative neoplasms.
Thank you so much for being with us today.
My pleasure.
As we do with each of the webinars in our Thrive series, let's start with this question. In your experience, what do you think it means to thrive with an MPN?
It's a great question, right? I think taking a step back, right, when we think about our patients with MPNs, one of the questions I always have for patients are, what are your goals? And inevitably and invariably, people want two things. They want to live longer and they want to live better, right? And so I think that thinking about thriving with an MPN to me is about how do we minimize the impact of an MPN in someone's life? And that means a couple of things. One, that means how do we deal with symptoms or things that are causing medical problems? But number two, how do we deal with the anxiety of the diagnosis? Because in many cases, in my experience, that can be just as detrimental to somebody's well-being as the actual physical symptoms of the disease.
When it comes to choosing therapy for polycythemia vera, essential thrombocythemia, or myelofibrosis, it's important to work with your healthcare team to identify what is going to work best for you. So to begin, would you define shared decision-making, and why is this critical to properly managing life with an MPN?
Yeah, shared decision-making to me is really about the physician or whoever's in the healthcare team providing the patient information, all of the information needed to make a good decision. Now, that means what are we trying to do? What is the medication or intervention going to accomplish? What are the side effects? Because there's always side effects. And what do we think that's going to do, or how is that going to impact a patient's life? Where things get, I think, nuanced is that patients come to us because we have expertise. And so it isn't, there's two extremes. One extreme is that the physician says, this is the medication you should take, end of discussion. The other extreme, though, is also not helpful, which is to say to a patient, here are 5 choices, here are the side effects, you pick one, right? Our job is to lay out those side effects and the benefits, but then also help guide a decision.
What are treatment goals and how are they determined?
It depends on the disease to a large extent. Now, when we're dealing with ET and PV, the primary goal of our interventions is to reduce the risk of a clotting event or bleeding event. And that usually involves controlling the blood counts. In some cases, not in all, in patients with ET, sometimes aspirin is all we do. Myelofibrosis is a little bit more complicated because it depends on what the problem is. Not all myelofibrosis patients have the same challenges. Some have anemia that needs treatment, some have a big spleen, some have symptoms, and some have nothing, and they just need observation. So it's a bigger list with MF patients, but I think the first part of the discussion always is defining what the goal needs to be.
Mm-hmm. Well, what factors are considered when choosing therapy for ET, PV, and MF?
Well, I think a couple of things, right? One is what medication we think is going to benefit the patient best. Now, that has to take into account the individual, their willingness to take certain medications, for example, pills versus interferon injections. Some people have an aversion to self-injection, which is, we have to take that into account. What are the other medical conditions that the patient is dealing with? And the reality is, in some cases, it's cost, because these medications, depending on a patient's insurance, can have quite a different spread in terms of cost. And unfortunately, that is something we have to take into account.
Mm. Well, let's talk about what sort of tests should be done following an MPN diagnosis. Can you tell me about those?
Yeah, I think, fundamental to the MPN itself, one of the things that we really want to know is, in most cases, a bone marrow examination is needed, because that will tell us really what the disease is that we're dealing with. It will tell us about the genetics. And I strongly believe we need to be comprehensive in our genetic assessments because that does prognosticate and sometimes gives us a opportunity in terms of treatment. Chromosomal analysis. These are kind of the basic bread and butter hematology tests we want to do from the bone marrow to really understand what the patient's disease is. Beyond that, I think that particularly in patients with PV and ET, it's important that we partner with their primary care physicians to make sure that they've had, for example, testing for diabetes, a recent lipid profile, any cardiovascular tests, particularly measurements of blood pressure, because these things are all important in terms of a ET or PV patient's risk of having a blood clot. So there are, again, things that are within the hematology realm, but then there are other general health things that become really important in somebody who's diagnosed with PV or ET.
Yeah. How often should lab tests or blood work be done?
Really depends on the patient. And for some patients with PV, for example, they need to have their blood checked every 3 weeks because they're having frequent phlebotomies, whereas some patients with ET could probably go 4 to 6 months between blood tests. So it depends on the individual.
Mm. How can results of biomarker testing affect treatment choices for patients with MPNs?
Great question. The genetics are becoming increasingly important in our treatment decisions. So let's take a simple example, which is patients with ET. Calreticulin and JAK2 and MPL-MIPL are the 3 most common mutations that we see, but they have very different implications. So somebody could have a calreticulin mutated ET, and based on them having that calreticulin mutation and no other factors like no history of clotting, that patient may never need to go on a medication aside from aspirin. And even early on, it's debatable whether or not some of these patients really need aspirin at all. Whereas somebody who has a JAK2 mutant ET, our guidelines and data suggest that person, once they reach a certain age, should probably be on medication. So that's kind of perhaps one of our more clear-cut examples of a genetic biomarker telling us, how to approach treatment. And then it gets more nuanced from that and more exciting and interesting in the sense that there are mutations, for example, that occur in myelofibrosis and in patients whose disease is progressing towards leukemia, such as IDH mutations. And these are things that are now targetable with FDA-approved drugs. And there are now clinical trials combining JAK inhibitors and IDH inhibitors for patients who have more advanced disease who have these IDH mutations. So you go from, on one end, these genomic markers being of prognostic significance, and now on the other hand, we're getting to a point where in some cases, they might tell us how to best treat a patient.
Dr. Rampal, should all patients diagnosed with MPNs undergo molecular testing?
I strongly believe that. I think that we've learned so much that these tests have prognostic value, and in some cases may suggest a slightly different diagnosis. I definitely think that should be the case.
Mm. What should patients be asking once they have the results?
What does it mean? That's the most basic and fundamental question, right? It's one thing to get a list of mutations, but the real bread and butter question is, what does this mean for my disease and my prognosis and my treatment? Those are the key questions.
So what are the types of treatments available for MPNs? And let's start with myelofibrosis or MF.
Myelofibrosis, if we had this discussion 5 years ago, it'd be pretty simple and it would take a minute or two. And that's completely changing, and that's amazing, and it's good for all of our patients. Right now, for patients with MF, it depends on what the issue is. If the issue is symptoms or spleen, JAK inhibitors are our first line of therapy. 3 approved JAK inhibitors are currently available, 2 in the first line, ruxolitinib and fedratinib, and pacritinib can be used for patients with really low platelet counts. There is a 4th JAK inhibitor that we expect to be hopefully approved in June of this year, momelotinib. So the landscape is about to completely broaden in terms of just JAK inhibitors. But beyond the JAK inhibitors themselves, there are a number of late-stage clinical trials that are combining JAK inhibitors with agents that work through a different mechanism, that don't work through inhibition of the JAK pathway. So far, these drugs have all shown promise in early phase trials. Now the definitive phase 3 trials are being done. We have to wait and see what the data tells us. But if these are positive trials, this could completely alter the landscape of MPN.
There's also transplants available, right?
Correct. Transplant for more advanced patients, which, comes with some major risks. And so that has to be thought of very carefully in terms of the risk and benefit, but it is a potentially curative strategy.
Let's turn to polycythemia vera, or PV. What types of treatments are available?
It's really quite a range. So there are things like phlebotomy and aspirin, which has been the mainstay of therapy for many years. There are drugs like hydroxyurea, interferons, JAK inhibitors. So ruxolitinib is approved in certain settings for treating polycythemia vera. So the landscape is broad. There's a lot of questions going on right now with polycythemia vera with regards to how it should best be treated. Is the mainstay of phlebotomy and aspirin really what we should be doing, or should we be giving patients treatment earlier on? And there is some data to suggest that. There is a drug called ropeg interferon that's FDA approved for polycythemia, which was compared in a study to phlebotomy and aspirin. And at least the data suggests that there may be better control of the disease and less progression, possibly. It's a small number of patients by treating patients earlier, whereas we would have just given phlebotomy and aspirin. So something to consider. There are drugs in clinical trials as well that look promising, one of which is called rusfertide, which actually works by changing iron, the way iron is utilized by the body. Iron is a key component of hemoglobin, and it is, of course, a key component of polycythemia, in the sense that we phlebotomize patients and make them iron deficient, and that's how we control the disease. But this is a pharmacological way to do that. So that drug is now in phase 3 trials. So that may also alter the landscape of treatment of PV in the near future.
Mm-hmm. Finally, how is essential thrombocythemia treated?
So in some cases with absolutely nothing, as we had talked about a moment ago, there is some thought that in really, really low risk patients, maybe you don't need to do anything except observe them, whereas most patients are on an aspirin. And beyond that, we have drugs like interferon, pegylated interferon, and hydroxyurea, and anagrelide, all of which can be utilized. It's not entirely clear if there is one distinct first-line treatment that is the best, but these drugs are all active. JAK inhibitors have been studied in this setting, and to date, the data hasn't led to their approval, but certainly people have studied it.
Dr. Rampal, how can you tell if a treatment is effective? Are there signs that you look for?
Well, I think it's a couple of things, right? Number one, are we meeting the treatment goals in terms of, are we controlling blood counts with ET or PV, right? That's one of the first principles in management. And with regards to MF, same thing. Are patients' symptoms being controlled? Is the spleen being adequately controlled? And then there's the symptom burden, right? Because just because the blood counts are being controlled, patients may still have symptoms, in which case they're not being adequately treated. And then we have to do our best to try to find a treatment strategy that does control their blood counts, but also does control their symptoms. So there is the blood count perspective, but there is the symptom perspective as well.
How do you know when it's time to change treatments?
Well, I think really two things. One is if we aren't meeting our goals like we just talked about, but the other aspect of that is if we are incurring toxicities that are just not tolerable to the patient, and that's a reason to change therapy always.
Many patients, of course, worry about disease progression. Are there key predictors or tests for progression that patients should know about?
This is a key area of investigation currently, right? I think one of the things that patients say to us so often when we meet them is, what's going to happen to me, right? Right now we don't have great prediction tools. We can say on a population level, well, there's X% of chance of progression at 15 years. That's useful if you're talking about a population. That's not really useful if you're talking to an individual, because if I say to somebody, well, there's a 20% chance of your disease progressing to leukemia, it doesn't really make a difference. That's a kind of a meaningless statement, because if you're in the 20% who progress, it's not a relevant statistic anymore. It's sort of a binary thing. We've got to do better at developing this. This is something that the MPN Research Foundation is really heavily invested in trying to identify predictive biomarkers. Because if we can do that, then perhaps what we can do is say to a patient, this is really what we think your actual risk is. And then the next step is asking the question, if we intervene early, can we prevent that progression from occurring? So that's where I think we need to go. We aren't there yet, though.
Yeah. What signs or symptoms do you look for that may indicate that the disease is progressing?
I think, it's the blood counts are often the canary in the coal mine, regardless of the disease. They can tell us if ET or PV is progressing into MF, or whether MF is progressing to more of a leukemic phase. Changes in symptoms sometimes can be a harbinger of disease progression. So patient who, for example, was doing really well and now is having drenching sweats and losing weight. So those types of symptoms are a sign. And then, physical exam findings like the size of the spleen, if it's increasing, all of those things together give us a hint about progression.
Yeah. Well, is there any way to prevent progression?
That is the million-dollar question, right? And again, that's where we ultimately need to be, right? We want to be able to intervene to a point where patients don't get that sick, right? Could we, be amazing if we've come to the point where we can intervene early and nobody progresses to late stage MF, nobody gets leukemia. And I think that's a worthy goal. That's not something that we should think is too lofty of a goal. That should be our ultimate goal here. And a number of groups are investigating this exact question. It's complicated and it's going to take time, but I think that's a worthwhile investment.
Let's talk about MPN symptoms and treatment side effects. Here's a question we received from a viewer before the program. How common is peripheral neuropathy in primary myelofibrosis, and what is the best treatment for it?
Well, by itself, it's not a very common symptom of MF by itself. Can it be a symptom? Sure. But there's also a number of things that can cause peripheral neuropathy. So I'm not sure there's a best treatment, but what needs to be done is a thorough investigation. There can be a number of causes. It can be nerve injury. It could be a deficiency in vitamins like B12. There's a lot of things that can cause it. So that type of a symptom needs to be thought of in a broad way in terms of diagnosis.
Okay. Jeff sent in this question. How can I manage the itching? Are there new treatments or strategies to live with itching?
Very common thing. And it's an interesting thing explaining to when we teach our trainees about this symptom, we have to impress on them the fact that itching is not the itching that everybody else experiences. This is a very profoundly different symptom. It's debilitating for so many people. Had patients go to the emergency room for that. That's how terrible it can be. There's a lot of things that can be tried. JAK inhibitors, in my experience, have worked very well if we're itching, but not in everybody. We use sometimes antihistamines that can work well. Sometimes antidepressants can work well, not because they're treating depression, but because of other properties that they have. And sometimes UV light therapy can be a useful tool here too. A lot of patients swear by it.
Huh. Another common side effect is fatigue. Mm-hmm. Do you have any advice for managing this symptom?
Fatigue is the most common symptom across MPNs. And it is also one of the most difficult things to treat. Part of the issue is trying to figure out what does fatigue mean to the patient, right? When someone says they're tired, does that mean they're sleeping all the time? Does that mean they don't have get up and go? The first step is always understanding what does fatigue mean to the patient. And then the second is trying to dissect that. And, in some cases it's related to anemia. In some cases it's not related to anemia and it's just the disease itself. And in some cases you have to think outside the box about general medical issues like thyroid dysfunction that could be at play here. So there isn't one best fit, but the first task is always to dig deep. When someone says they have fatigue, to dig deeper and try to figure out what does that really mean.
Mm-hmm. What other common symptoms do you hear about from patients, and what can be done about those?
Yeah, there's there's a lot of different things. It's a spectrum, right? And so I think that itching, fatigue are very common. Feeling full early, that's a big thing, particularly in myelofibrosis patients. Bone pain, that's another big one, particularly in myelofibrosis. There's not one therapy that is best for all, right? I think the JAK inhibitors certainly benefit many of these symptoms, but they don't benefit everybody, and not to the extent that makes it tolerable for everybody. So oftentimes we struggle with this and tried, a lot of different things. But again, I think one of the things to always remember is we don't always want to say that this must be because of the MPN. Sometimes symptom is arising because of another medical condition that's going on concurrently.
Yeah, okay, that's good advice. Thank you. Let's answer a few more audience questions we received. This one is from Calvin. If your hematologist says you are stable and responding well to Hydrea, should you still seek out a second opinion?
It's never wrong to seek out a second opinion. I mean, I strongly believe that, especially when you're dealing with this disease that's rare like this, right? And even seeking out a second opinion, even if you're under the care of an expert in the field, is never a wrong thing. I think that no one person knows everything, and sometimes people's experience and perspective is different. So I don't think that's a bad thing ever.
Yeah. As a follow-up to Calvin's question, is it sufficient to just look at what the blood tests reveal, or does having a bone marrow biopsy dictate what treatment you should follow?
Yeah, I think the bone marrow is important, particularly at initial diagnosis or when there is a change. The blood counts are the canary in the coal mine, right? So they tell us, is there something else going on that we're not thinking about? And that's when the bone marrow becomes important. So I definitely think a bone marrow is important at certain points in the disease.
Okay. Sandra has this question. Are there new treatments for polycythemia vera being researched beyond interferon?
Yeah, so we talked about rusfertide as an example of this, right? And there are certainly other drugs that have been evaluated in this space. So there's a lot of work going on for this disease, which is really encouraging.
Carolyn sent in this question. Is there a possibility of bone marrow fibrosis reversal in myelofibrosis without a stem cell transplant?
The answer is yes. So even with JAK inhibitors, we see that about a third of patients will have a reduction in bone marrow fibrosis. And this is a key question being investigated with some of the newer therapies that are being introduced into the treatment of myelofibrosis. And certainly we've seen data to date that suggests that the fibrosis can be reduced, if not potentially eliminated in some cases.
Andrew wants to know, does Jakafi cause other mutations to develop?
That's a really good question. Right now, we don't think the answer is necessarily yes. We have seen that in some patients where the disease has progressed on Jakafi, mutations have emerged. But the problem is that genetic testing has limits of detection. In other words, if a mutation appears, it may not have just appeared or been caused by the disease, or the drug rather, but that it may have been below our limits of detection and actually grew while the patient was on therapy, which does not mean that the drug caused the mutation, but that it was allowed to emerge during treatment with the specific drug. So that is an area of investigation.
Well, thank you, Dr. Rampal. And please continue to send in your questions to question@powerfulpatients.org, and we'll work to get them answered on future webinars. You mentioned earlier clinical trials, and I'd like to dig a little bit deeper. Where do these fit in to the treatment plan?
I think they should always be considered, right? None of the therapies that we have do we consider curative. And in many cases, standard therapy is fine, right? It's given a patient's clinical situation. In a case where standard therapy is not working, or where we think that a patient's prognosis is particularly challenging, or if they have mutations that may confer resistance to current therapies, I think in those scenarios, a trial should always be considered.
So if a patient is interested in possibly participating in a clinical trial, what kind of questions should they be asking their healthcare team?
Well, all of these trials are different. And, I think the first thing is to discuss what's the risk? What's the benefit of any given trial or drug? What stage in development is it? What's the evidence to support it? And what can I expect from it?
What about cost?
So trials in general have two components. One is what we call standard of care, meaning that things we would do normally in the course of a patient's treatment would be billed to a patient's insurance as if they weren't on a trial. But in almost all trials, the study drug or any tests that are being done specifically with regards to the study drug are all covered by the whoever's sponsoring the trial.
How do patients find out about where the clinical trials are taking place?
Usually, their physician should either, if they're in a specialized center, they'll have access there. But if they're interested in trials and they're being seen, for example, by a physician in the community who doesn't necessarily specialize, asking for a referral to a major center with that MPN expertise is not an unreasonable approach to that. There's also clinicaltrials.gov where patients can go look for ongoing trials for their particular diagnosis.
If patients want to learn more about MPNs, what sort of resources would you recommend?
The thing I always say to patients is the internet is a very dangerous place for a variety of reasons. We have to, I think, do a good job of communicating to patients what are the resources. And the ones that I always point patients to are, for example, the MPN Advocacy International, the MPN Research Foundation, the Leukemia Lymphoma Society, and the American Cancer Society. Those are, sources of information that are vetted by physicians. Some of that information is specifically for patients. Those, to me, are good sources for patients to read.
Well, Dr. Rampal, as we close out our conversation, I wanted to get your thoughts on where we stand with progress in MPN care. Are there advances in research and treatment that make you hopeful?
Without a doubt. I think I've seen more progress in the last 3 years than I've seen in the last 10 years. And we have so many new drugs coming forth, new questions that we're trying to answer, tough questions, as you alluded to, right? The question about prognosis, but also intervening early to prevent progression of disease. These are things that are difficult questions that we are trying to dig into now. So I think we should be optimistic. We are seeing so many excellent developments. We'll have to see how far they're going to take us. I don't think we know the answer to that, but this is an exciting time.
Dr. Rampal, thank you so much for joining us.
My pleasure.
And thank you to all of our partners. To learn more about MPNs and to access tools to help you become a proactive patient, visit powerfulpatients.org. I'm Catherine Banwell. Thanks for being with us today.